For a short introduction, looking at some of the theory, then we've got some amazing expert speakers that have been arranged to run some case studies exploring the management of hypertension in these conditions, which, as you know, are often quite complex and overlapping. What we're not going to cover is general hypertension detection and management on this occasion, just due to time. So this is the agenda and our list of speakers for the session. So hypertension is the leading modifiable risk factor for cardiovascular disease, and it's estimated about 15.5 million people in the UK have hypertension. For those that we know about, 37% of them are uncontrolled, and there's an estimated 7 million people who have hypertension but aren't on hypertension registers, so they're walking around with high blood pressure but we don't know about them. Hypertension is the leading cause for chronic kidney disease and a significant contributor for both heart failure and atrial fibrillation. It contributes about 20,800 deaths a year in England, and it's also the biggest contributor to adult disabilities, predominantly through its impact on stroke rates. It costs the NHS in England around 2 billion a year, so it is really expensive. And the most important thing about hypertension is that it's usually asymptomatic, so people don't know that they have it until they have their blood pressure checked. So a normal blood pressure is generally accepted internationally to be less than 120/80. However, there are some international differences in opinion on where high blood pressure starts. But according to the NICE guidelines, stage 1 hypertension is defined as a clinic blood pressure of 140/90 or higher, and subsequent ambulatory or home blood pressure monitors of 135/85 or higher. So people with underlying cardiovascular disease, those with diabetes, CKD or obesity alongside their hypertension have got the highest risks for major adverse cardiac events, such as heart attacks and strokes. And we also know that certain ethnic groups are at higher risk of hypertension and tend to have poorer outcomes, both in terms of the control of their hypertension and also the cardiovascular disease outcomes. So when we're tackling hypertension in your practice, these are the people that we should be prioritising. So there is a complex interplay between hypertension, heart failure, CKD and diabetes. And many of our patients will have cardiorenal metabolic disease and will either present with or progress to having a combination of these conditions. The most common interacting pathway for hypertension, pathophysiology in these diseases, is the renin-angiotensin-aldosterone system, quite a mouthful, also known as RAS. The heart failure, kidney failure and diabetes all lead to activation of that RAS system. The mechanisms are multifaceted, so I'm not going to go into loads of detail. However, the key point is that activation of RAS alongside some other mechanisms drive hypertension in these diseases. So a few general points on pharmacotherapy for hypertension in heart failure, CKD and diabetes. You will note that management of hypertension and frailty is really different, so Heather's going to cover those specific points there. So as I mentioned, you know, RAS activation is one of the major drivers of hypertension in this population. So RAS inhibition with ACE inhibitors or ARBs are generally first line. You will tend to find that EGFRs will drop with initiation of these drugs, and a drop of an EGFR of up to 25% is acceptable. However, if you observe more than 25% drop in EGFR, we should be exploring other causes and titrating drugs more slowly. But the most important point is that we shouldn't just be stopping ACE inhibitors and ARBs because of EGFR drops. First dose hypotension is more common in these diseases because they often have orthostatic hypertension. So remember to tell people, sorry, not orthostatic hypertension. My brain's gone, sorry. I'm having a moment. But anyway, remember to tell people to take these at night. In these diseases, specific treatment pathways may support blood pressure reduction. So you might see patients on different drugs to what we would usually see in essential hypertension that are supporting BP reduction. Patients with these conditions should have their blood pressure monitored with lying and standing blood pressure, as orthostatic hypertension can occur due to autonomic dysfunction. That was the word I was looking for earlier. Always remember to check adherence as well before adding in new therapy for blood pressure, even more so importantly in these patients because we get a lot of polypharmacy. Sick day rules apply to everybody on ACE inhibitors, ARBs, diuretics, and SGLT2s generally. And I'm now going to hand over to our first expert speaker, who is Heather, who's going to discuss the management of hypertension in frailty.
Thank you. So my name is Heather Smith. I'm a consultant pharmacist for older people, and I'm based in the Leeds office of the NHS West Yorkshire Integrated Care Board. Next slide, can I put that on? Okay. So just some general points about blood pressure in older people, and I appreciate that what I'm going to tell you might be at odds with what you would do in younger, non-frail populations. So older people have arterial stiffening, which increases their systolic blood pressure, but their diastolic can remain the same or even decrease. And sometimes we call this isolated systolic hypertension. And the systolic blood pressure is a predictor of outcomes rather than the diastolic in older people. They also have impaired blood pressure homeostasis and increased blood pressure variability, and they're at increased risk of orthostatic hypotension. So this is also co-postural hypertension. So it's when people's blood pressure drops when they change position, for example, from sitting to standing or lying to standing. And orthostatic hypertension is associated with increased mortality, cardiovascular events, and falls. Older people are also more commonly have white coat or nocturnal hypertension. So white coat hypertension can be more than 50% in older people. So it's really important that we check lying and standing blood pressure routinely, and we don't do this very well. And that's probably because it takes time to do it properly. And we should also do repeated office or preferably home readings to make sure that somebody does have a raised blood pressure before we treat them. And it's also really important that we consider an older person's global function. So thinking about their comorbidities, so they may be on other medicines that reduce blood pressure for other conditions, their frailty status, their level of independence, their cognition, and the other medicines that they're taking. So there is no global consensus on blood pressure targets for older people. So experts can't agree. So we've got the NICE hypertension guidelines, which has an age cutoff rather than based on functional frailty, but they do say use clinical judgment for people with frailty or multimorbidity. And that might mean accepting a higher blood pressure target, especially if that older person has symptoms of orthostatic hypertension, if they're struggling with their tablet burden and the other medicines that they're taking, or if they have limited life expectancy. Large blood pressure lowering trials are generally in relatively fit older people, although some did have moderate frailty. And older people, especially those with living with frailty, are more likely to have adverse drug reactions, drug-drug and drug disease interactions. And we need to be really careful around aggressive blood pressure treatment in older people living with frailty. So there is some literature that shows that it induces falls, and it might actually increase their mortality, particularly in those with cognitive impairment. Sometimes we have people with supine hypertension, so this is raised blood pressure on lying down and orthostatic hypertension together, and that can be really difficult to manage. But we're trying to aim for a diastolic above 70 in those patients. And often the lifestyle advice, so for example, with salt and weight reduction, it can be inappropriate and can have unintended consequences in older people, particularly if they're living with frailty. So to try and illustrate this, I've got a case. So this is Alice. She's 78 years old and she's had a recent admission with fall and dizziness. And the symptoms sounded postural in nature. So fludrocortisone was started in hospital, which increases salt and water retention and increases blood pressure in people with orthostatic hypertension. She was checked for benign paroxysmal positional vertigo and wasn't found to have that. And she was also noted to have a poor oral intake, which also increases the risk of orthostatic hypertension. So when we talked to Alice about what mattered to her, she was really worried about feeling dizzy, falling and injuring herself. She used to enjoy gardening, but she can't do this now because of the dizziness. And she doesn't want to go out because she's worried about falling outside. So what are Alice's past medical history? So she's living with moderate frailty. She's got a history of hypertension, falls, paroxysmal atrial fibrillation, and vertigo. Her blood results are pretty unremarkable. She's previously been treated for hypertension with ramipril and valsartan, but she's had to stop these due to low sodium, and these are irregular medicines. So she's on bisoprolol for AF, cholecalciferol, a vitamin D, edoxaban, an anticoagulant to prevent stroke from the AF, the fludrocortisone that she's just been started on in hospital, and simvastatin. So in hospital, when the fludrocortisone was started, this was a lying blood pressure 127/78, and the standing blood pressure was 119/70. So this is a non-significant postural drop. So significant is usually when the drop in systolic is 20 millimeters of mercury or more, or a drop in the diastolic of 10 millimeters of mercury or more. But the fludrocortisone was started because her symptoms and her dizziness seemed to be related to postural changes. So after discharge, the GP was asked to monitor the lying and standing blood pressure and UNEs. So her UNEs remained stable, but these are her blood pressures. So obviously the first one that was done in July was really high, and then still outside the NICE guidelines in later on in July. So this patient came through to me through my advice and guidance service because the people in primary care were worried about the increase in blood pressure due to the fludrocortisone, but also worried about stopping the fludrocortisone due to falls. So I don't know if anybody wants to put in the chat any thoughts that they might have about what to do with this lady, or what things they might want to talk to her about. Is everyone being shy? Has anybody got any thoughts on her pulse? Yeah, so pulse seems high. Yeah. So she's got a high pulse and a high blood pressure. So when we went back to talk to Alice, we found that because of her previous falls and because she was fed up, she wasn't taking her medicines reliably. So actually, the reason that her pulse was high was because she wasn't really taking the bisoprolol. So we talked to her about the fact that AF itself can cause dizziness and can contribute to falls. So taking her bisoprolol was really important. To be honest, I wouldn't have been that bothered about her blood pressure being 159/85, even if she had been taking the bisoprolol reliably. But obviously, if she does take it reliably, her blood pressure is probably going to be a little bit lower. And so that's what the discussion that we had with her, and actually her blood pressure has come down a little bit now that she's taken the bisoprolol, and her blood pressure is a little bit lower than it was. So her AF's controlled, and she's happy to take those medicines. But sometimes when an older person, we have to talk to them about the medicines they're taking, and we might have to knock off less essential medicines to make sure that they're taking the medicines that really make a difference to their outcomes. So that's it from me. So I've just put a few links on there about how to check lying and standing blood pressure, how to treat orthostatic hypertension, and the European Society Hypertension Guidelines, which do have some information on isolated systolic hypertension and management in older people. So thank you, and I'll pass. I don't think there's time for questions, but I'll pass over to who's next, Hannah.
Thank you. Sorry, we're having some issues with the slides this end.
So case study in hypertension and diabetes. So my name's Hannah Bieber. I'm a consultant pharmacist in diabetes at Leeds Health and Care Partnership. So today, I suppose with this case study, what I really wanted to illustrate was how hypertension and diabetes is sometimes quite complicated, and depending on the person. I've only used one case today because I could go into this for decades, but I think it's just illustrative to just show that actually sometimes when we're following protocols and guidelines, sometimes people don't fit into that, and sometimes that creates complexity and difficulty. So I just wanted to run through that. So this is our first case, is a lady who's 42 years old. She's had diabetes just for 3 years, and her current medications are quite simple, quite straightforward at this point in time, which is potentially, I think we're all used to seeing a list of about 20 medicines for people living with diabetes as they progress through their disease. But for her, just metformin 1 gram twice a day, atorvastatin and some paracetamol. She's got high BMI, her HbA1c is 64, which is a little bit above where we would target somebody, particularly at this age, and she's got some microalbuminuria, but this appears to be stable at the moment with a slightly reduced eGFR, but nothing that would qualify her as having significant CKD at this point in time. LFTs are normal and her TFTs are normal. And Mrs. DM's initially had a blood pressure of 158/98 in her left arm, and the clinician then rechecks her blood pressure in the right arm, which is 162/99. And her blood pressure, though previously to all of this, has been perfectly normal. So this is a bit of a shocker at this point. And what are we going to do first? And is there anything that we would do differently if she came in with a really high blood pressure at that clinic reading? Now, this is quite, it's quite common for me to be in a clinic where somebody has a deranged blood pressure. I think I put the fear of God into people, to be honest, but often if you let people settle into your clinic, it does change and sometimes settle much lower than that. So what I would recommend is that we do try to take clinic readings on different days at the very least, and not just take one reading, certainly if it's just, and especially if it's been normal previously in the past. Also kind of some exploration about what's been happening with her that day. Have they been rushing around? Have they just run into your clinic, etc.? Also, if you were over 180, over 110, we can be fairly certain that they do have hypertension. At that point, you can give that diagnosis. And we can also look to do some ambulatory blood pressure monitoring, home blood pressure monitoring, just to confirm. So that would be what I would normally do. So for the first time of presentation, I would definitely do some further readings on different days, and make sure that if you've got ambulatory blood pressure monitoring or home blood pressure monitoring, that would be ideal to send them away to do that, and then give them a diagnosis if they hit the threshold of over 180 over 90. Blood pressure management in diabetes, you would measure blood pressure at every visit with somebody with diabetes. That's just to kind of get a good idea about what's happening over the course of time, and allow people, like I've said, to be sitting comfortably, approximately 5 minutes at least of rest before you start taking those readings, and taking three readings, normally about 1 to 2 minutes apart. And then additional readings of the first 2 readings differ by more than 10 millimeters of mercury, and you average normally the last 2 readings to give you your final reading there. And you measure blood pressure 1 minute and then 3 minutes after standing. So orthostatic hypertension is really something important to rule out in people with diabetes, because you can get neuropathies that lead to postural hypotension. So with people with diabetes, it's really important that we do assess whether somebody has orthostatic hypotension. It's actually quite a long time for somebody to stand up sometimes as well, so that's something to consider. Obviously, Heather's just gone through the frailty piece, but if somebody's older, not this case specifically, but if somebody's older, to ask them to stand up for 4 minutes here can be quite a lot for them. So and actually it just seem to take a long time, and they wonder what you're doing, but you can whip through some of your other stuff while they're standing there. Next slide, please. So after properly assessing the patient's blood pressure, her average blood pressure is about 155/95, and there doesn't appear to be any postural hypotension. So what are we going to do now? What are the target blood pressures that we're aiming for, and what other information do we need? So in diabetes, this has been a hotly debated subject, and we've gone backwards and forwards with these things. But one of the big trials in diabetes, called the UK PDS study, which has looked over a 10-year period get people actually from an outcome point of view, a target of 140/90, just a normal blood pressure target, is actually perfectly acceptable for most people unless they've got significant renal dysfunction, and so from a mortality and morbidity point of view, you're not going to do them any disservice from doing that, and it's easier to remember. So we decided to align ourselves to everybody else at this point. So what are we going to recommend here to help blood pressure? And there's lots of things that we can do to help. Dietary and lifestyle options are always a go-to, and long-term exercise training intervention is modestly but significantly reduces your systolic, so about 7 millimeters of mercury, diastolic by about 5 millimeters of mercury. So trying to get somebody to both establish an exercise regime but actually stick to that exercise regime is really important. And you know, we've obviously got social prescribers, some of these lifestyle advisors now into primary care, that actually, if we can get people working with people to give them exercise prescriptions, for example, and use people's skill sets to really push on these sorts of things, and that would be aimed at lowering the blood pressure, including a mix there of aerobic and dynamic resistance exercise training would be ideal for somebody with diabetes. And this produces a marked improvement in cardiovascular risk factors, hypertension definitely, but we're also doing good for other things as well, which is worth remembering. So around the dyslipidemia and also the diabetes itself, often associated with a marked weight loss. Something to kind of specifically to diabetes, and something that we should remember, is that actually for this person in this case, she's only had diabetes for 3 years and she's very young in age. So it's possible that she would be appropriate for the remission program for diabetes and can be referred through to that national remission program, which would normally yield around a 15 kilo weight loss, similar to bariatric surgery in its results out the other side. So we would expect, if somebody has attended a remission program, that they would therefore get significant reductions in hypertension, and we would need to actually actively deprescribe hypertensive medications before they went into starting the remission program, which is normally done as the pre-assessment for that program. But that's just to kind of a diabetes specific point to raise, and specific to this patient because she's young. Why not try to reverse the diabetes while you're within that sweet window of that 5 years post-diagnosis? And pharmacotherapy for the blood pressure specifically, obviously normally we'd say in diabetes that ACE inhibitors would be our first line medication, and we need to try and commence that if possible. But what else might we need to think about with this particular patient? For her, she's 42, she still may be of childbearing potential. Obviously the RAS blockade does have significant adverse effects on a fetus, and so we need to know whether pregnancy is being planned and whether contraception is something that is being used. And the evidence for RAS inhibition is strong in diabetes if this isn't an issue, particularly for those with already having signs of renal decline. And as I've already mentioned, this lady's already got microalbuminuria, so protecting kidneys in a young person with diabetes is really important. And sorry, Sunil, and you'll probably coming into this eventually as well, but really important, very important to protect your kidneys as you go forward with diabetes. And in a young person with type 2 diabetes, this is a very aggressive form of type 2 diabetes, a very aggressive phenotype of diabetes. So protecting and doing well with risk factor management such as hypertension is even more important than in older people diagnosed with diabetes at later age. And there's been a recent meta-analysis which indicates that RAS inhibitors were not superior to other classes of antihypertensive for reducing total or cardiovascular mortality in renal events. So I suppose that takes the pressure off a little bit around always making sure that you start an ACE inhibitor. There are other drugs. Really, the main goal is to make sure the blood pressure is checked away into target area. Also, there are obviously often other multiple therapies needed. Very rarely will somebody with diabetes only require one blood pressure lowering medicine. There's calcium channel blockers and diuretics would be a favourable add-on. And again, we're looking back at whether a child is planned in the future. And if planning for pregnancy, beta blockers are useful. Beta blockers have got really bad press around diabetes due to them masking some of the effects of hypoglycemia. However, very rarely is that an issue. We've got cardio-specific beta blockers now, which overcome that as an issue. But also, this patient isn't even on anything that's going to cause a hypo in the first place. So we need to be sensible. This only applies to people who might be already at risk of hypoglycemia in the first place. Pharmacotherapy with glucose lowering agents. So I saw that somebody put in about the SGLT2, so I'm coming to that, don't worry. So glucose, how are you going to choose your choice of glucose lowering agent that might help your blood pressure as well? And the SGLT2s are definitely something which does show a reduction in systolic and diastolic blood pressure. So if you're adding an SGLT2 in, you might want to add that in, see where you land therefore with your blood pressure, and then make further blood pressure and medication changes after that. For her, this would be a good choice again, because you're protecting kidneys, you're protecting your heart, and you're managing the out of range HbA1c there, and you're going to check away. It's obviously does cause a slight weight loss, the SGLT2s, which would then therefore further benefit blood pressure lowering. So the SGLT2 inhibitors induced a larger blood pressure decrease than GLP-1s actually, without changing the heart rate, which is quite attractive. And that was from a recent meta-analysis which looked at that, and the average reduction was about 3.6 and 1.7 systolic diastolic in a 24-hour ambulatory blood pressure monitoring study that was done there. So this is comparable to low dose thiazide treatment. So just to give you context there. And then my last slide, I think, is around GLP-1s. So again, this might be a therapy that might be indicated in the future. She wouldn't meet nice criteria to start a GLP-1, but I'm hoping that we're going to have access to using GLP-1s earlier in younger patients developing diabetes, for all the reasons that, again, it protects kidneys if you've got albuminuria, avert albuminuria, but it also is very cardiovascularly protected. And going back to my previous point, young development of type 2 diabetes is a very aggressive form of type 2 diabetes that will develop into complications. So using these drugs earlier in treatment will be something that I hope will come in the future. But trials testing GLP-1s have shown that a blood pressure does decrease with these drugs, mostly associated with the weight loss that we get. And obviously we're getting more and more efficacious GLP-1s. Tirzepatide is coming hopefully by the end of this year, which is a dual incretin therapy, a GLP-1 GIP therapy, and hopefully again we'll see even more blood pressure reductions and better results with HbA1c and weight loss. So again, systolic blood pressure lowering of about 1.3 to 2.6, so fairly minimal, but still you're getting some, you are getting some benefit from adding in your glucose lowering therapies. So I'll leave that there. I don't know whether there were any questions, Emily, but we can come back to that at the end.
There's no other questions in the chat. Thank you, Hannah. Hand over to Sunil.
Thank you. Hello, good afternoon, everybody. I'm Sunil. I'm one of the consultant nephrologists at Leeds Teaching Hospital, and I'm also the CKD lead for West Yorkshire. It's always good to come after two brilliant talks, because quite a significant information has been covered. And I've already seen the slides beforehand, so I'm not going to repeat any of those messages, but you'll see some parallels there. Next slide, please. So this is, when it comes to kidney and blood pressure are close mates. You know, they go hand in hand. Most importantly, kidneys is the most important organ to regulate the blood pressure, whether it's a salt, whether it's a fluid, whether it's, you know, renin-angiotensin system, all of that are based within the kidney. So it's not a surprise that when you have a patient with kidney disease, almost 80% of those patients will have high blood pressure. And if you got a patient with a high blood pressure, 1 in 5 will have a kidney disease. So that's a really key message to take home, is they go hand in hand. If you're managing one, always think of other. What also is clear from other colleagues' talk, when you're managing blood pressure, it's obviously one is the end organ damage, which is of interest for me, for example, kidney disease. But most of my patients, unfortunately, suffer with cardiovascular disease. So when you're managing blood pressure, the aim is really to reduce those cardiovascular disease burden. And as a byproduct, you could perhaps improve the kidneys and improve the renal events as well. Next one, please. So I'm going to talk about a real case. It's a 20 years of journey, so you could see where it starts and where this patient is now. I'm going to bring in various aspects of management, and we'll make some important messages in terms of complexity, but also interdependency on various other things that sort of works in. So this is a gentleman who's not that old. This is the very brief sort of things in front of you. He's an ex-smoker. He's very obese, and that's his blood pressure. I'm not even saying that he's got diabetes, because you would probably be thinking, gosh, South Asians with all of that characteristics, he will have that as well. So I've kept the diabetes side of out. This is when it started in 2002. And you could see those red boxes are the one that I feel are the missed opportunities. So if a youngish chap coming with a blood pressure, it is fair enough to say it's all obesity related or essential hypertension, but you always have to think about secondary causes. And I would urge, if you have somebody with blood pressure, please at least do a urine ACR, at least assess the kidney function. This particular chap, as you could see, for 3 years since the diagnosis, had treatment but not had a creatinine. And actually, after 7 years of diagnosis and with a raised creatinine and a blood pressure, gets a urine albumin creatinine ratio check. Now, why am I saying this? Well, the urine albumin creatinine ratio is sort of a doorkeeper for all the exciting drugs, like Hannah mentioned about SGLT2 inhibitors, and it's also used in patients without diabetes. If you don't have the urine albumin creatinine ratio, then you could argue some of these patients are disadvantaged, not only from SGLT2 inhibitors, but also ACE inhibitor, which you'll see later on why that's really important. The second point I want to make here is this gentleman gets a code in the GP record as CKD. Now, why is that important? Well, having a diagnosis of chronic kidney disease in GP register has shown the care is better. The outcomes such as myocardial infarction, stroke, unplanned hospital admissions, all of them are better metrics if you have a code entered in somebody who's got albuminuria, even microalbuminuria for that matter, because even if the GFR is 90, if we have microalbuminuria, they technically have a chronic kidney disease. So it's really important to highlight in the early stages where this gentleman has been started on a beta blocker, a diuretic, he's got CKD and with an albuminuria and sort of enters that code. The other thing, just to emphasize, quite a lot of patients get pain, and by reflux, we are quite used to give non-steroidal anti-inflammatory. Some of them we prescribe ourselves, for example, diclofenac sodium. Some of them they can easily get over the counter, quite cheap on Tesco's or wherever really, like ibuprofen. So really important to educate that you've already got 3 sort of risk factors here. You're obese, you've got hypertension, you're ethnic minority, you're on 2 different blood pressure tablets, and you're given now non-steroidal anti-inflammatory, which not only potentially damage kidney, but also makes the fluid retention and the blood pressure control an issue. So just have a think. So I'm going to ask colleagues here, that's sort of back in 20 years journey. What would you have done differently, in 2023? So share your thoughts on, it might be things like referring to us, or what do you think you would do given that case? I'll pause for 10 seconds. Maybe that's enough. Okay, so maybe colleagues will, I can't see anybody typing. So next slide, please. This is the most up-to-date sort of approach, and quite surprisingly, it's no different than what Hannah has said in terms of, first line, second line, third line, and I'm sure this will be the same thing that will be said by our heart failure colleagues. So essentially, we're all doing the same thing, because the drugs, the choice really are focusing on reducing cardiovascular disease. in that as a byproduct. If you save kidney, that's great. So the top of the slide really tells you a little bit about CKD and hypertension and how they go hand in hand in terms of pathogenesis, in terms of inflammation, in terms of arterial stiffness, etc. When you get somebody in a situation of hypertension and CKD, non-pharmacological therapy and pharmacological therapy needs to go hand in hand. You obviously can withdraw pharmacological treatment if suddenly, somebody has made a massive lifestyle change and, has turned the corner. So I think, although it sort of says start non-pharmacological treatment, I would say start both simultaneously. And then assess if you have to withdraw a drug. That's much easier than actually leaving them, on lifestyle intervention for 6 months, 1 year, and then coming back to them at a later stage. So the key thing is, as I said, urine. If you don't do a urine analysis, the choice, the protective drugs patients would miss. So the most current recommendation from NICE is if urine albumin creatinine ratio is over 30, the first line of treatment would be ACE or ARB, depending on obviously side effect. Most often it will be ramipril, or if they get cough or other symptoms, then you go to ARB. The second line is calcium channel blocker. If you don't have proteinuria, it doesn't matter which one you choose, but those will be the two ones that go. Now, then you assess them within a month or 2 months to see if you achieved the blood pressure target after optimizing to the maximum dose. If the blood pressure in somebody with proteinuria is over 130 or 80, we say that's uncontrolled. As compared to somebody who don't have proteinuria, it'll be 140 or 90. Now, again, at this point, really important to emphasize the next choice depends on range of things. It's age, comorbidity, frailty, race of individual, what other medicines are co-prescribed, what's the level of kidney function. A lot of this comes into equation, what's the fluid status. So often I would say at this point where you've tried 1 or 2 agents with somebody with proteinuria, somebody with hypertension, we're thinking about getting to a specialist service where we could do some of those assessment and go through those third and fourth line of drugs. And again, I wouldn't go too much into detail, but the key message is if you got a blood pressure issue and CKD, often you will need a combination of drug. You're not going to find a magic bullet that will just, help one, the blood pressure. Next slide, please. So coming back to the case, so this is so the gentleman had a CKD diagnosed, code. He then takes another, nearly 8, 9, 10 years before he needs to see renal specialist. But again, highlighting some of the areas where the monitoring could have been better. For example, of selected key blood test and results every year. You could see in 1 year there was no kidney function assessment done, and the consistent theme is it's quite easy to get a blood test done, but extremely hard to get this urine albumin creatinine ratio. And I wonder why that is the case, because when you actually request, you print out both the forms and you hand over to the patient, but obviously one of them is in patient's hand to pass urine, another one is in hand of healthcare professional to draw the bloods. So maybe a little bit think through that and how you can improve that. Anyway, the gentlemen do get ramipril eventually when urine albumin creatinine ratio sort of goes to 69. And then a GP review in 2014 says, well, you're a bit obese, actually. We need to do something about it. You've done 10 years of lifestyle, nothing really has moved. So consider orlistat briefly. I'm not clear why it got stopped. And then the gentleman has been thinking about bariatric surgery from 2014. And again, he gets another, risk gout attacks. He got indomethacin, which again is a non-steroidal anti-inflammatory drugs, colchicine. Finally gets a renal referral in 2017 when the GFR drops to 29. Now, the question is, when would you have referred this chap? Would you have referred him in 2010 when urine albumin creatinine ratio reached 69? The current NICE guideline is a renal services referral if it's over 70 or over. I mean, that's not too different. You could argue that his kidney function has slowly been going down from 57 to 46, and it continued to go down further. Is that now, do you think renal service are going to do something that will stop this progression? Do we have anything that we could sort of reverse it? Next slide, please. So these are some points. We no longer say refer to renal if GFR is less than 30. That's an olden thing. The new thing is kidney failure risk equation, KFRE. Now, the laboratories are not giving that readout. Hopefully, we should be getting that in West Yorkshire, maybe from the new year. But you can easily calculate that KFRE on that website. So if your patient's got more than 5% risk of kidney failure next 5 years, they ought to be referred, irrespective of GFR. Not everybody less than 30 needs to come to renal services. They are already, elderly people. Even if the GFR is 20, they don't need just per se by the eGFR to come to us. And then I've listed some of the other indications, which I won't go too detail, but you'll have these slide sets later on. Next one, please. So you'll be interested, what has happened to that patient who was referred in 2017 to renal service? I'm afraid you could see if, one of the first thing I do is I plot the chart, an easy function on ICE OpenNet. You click eGFR, butter and graph, you see that he was on a slippery slope a while really before coming to renal services. We tried a lot working on his weight, working on his blood pressure, various things. Unfortunately, in 5 years down the line, he's now got a fistula and he's waiting to start hemodialysis. Now, you'll be thinking, why hemodialysis? Why not transplant? Well, his BMI is 51 right now. We can't transplant anybody over 35 because of outcomes are so worse. So he's sort of stuck now, really desperate that he doesn't want to go on dialysis. He's a businessman, really earning hard. But strange enough, 20 years of care, we can't fix it that quickly. Next one, please. So just finally, a couple of thoughts. When it comes to blood pressure, when it comes to the target culture, I want to make a couple of points here. So the one on the left side shows blood pressure effect and kidney damage. The bottom one, which says benign nephrosclerosis, means if you just had blood pressure, the kidney function decline is really, really slow. Unless if the patient get into an accelerated phase or a malignant phase, then the kidney damage can happen very quickly. However, if we have other disease like diabetes or obesity or other drug-induced, and if you have a kidney disease, then even at lower blood pressure, the kidney damage can be quite rapid if it was just hypertension driving the kidney disease. So really important to account that when you're managing patient in front of you, because we don't manage disease, we manage patients, and there are so many multiple interacting things. So the slide on the right side makes the same point. The graph on the right side. Number of long-term conditions and the blood pressure effect on kidney is quite different. If you have more health condition, the blood pressure effect on the kidney is much more pronounced. So really important point to remember. Next one, please. And the other thing about the target culture, well, it's all great, nice. I've got some numbers, but you have to treat the patient in front of you just like an old frail person. You have to look at the progression of the patient, the proteinuria of the patient, the ethnicity of the patient, and I would say, genetic susceptibility is so different. You can't have one number, and that's why sometimes we will confuse you, saying this patient, we expect blood pressure target of 110 over 70. Another patient will say 125 or 70. So there is always a bit of a room where you have to use individual judgment and personalization when it comes to long-term conditions. Next slide, please. And final couple of slides, which is about resistant hypertension. Now, what does that mean? Well, if the number is different if you have proteinuria or not. Generally speaking, if they need more than 3 antihypertensives, you ought to be thinking about resistance. Now, before you label someone with resistance, the measurement techniques are important. The good old office blood pressure is no good. It needs to be standardized blood pressure, ambulatory blood pressure. And the second important thing is adherence. We know the data that 25% of patients with polypharmacy don't take drugs. So adherence is a big thing, and you can easily check that with a spot urine analysis. You can send that to the lab. You can look at the blood pressure tablets or metabolite to see if they're adherent or not. And then obviously, if you've ruled all of that out, you refer to renal services. Next slide, please. So what am I saying here? Well, kidney disease and hypertension go hands in hand. It's really important when you're managing hypertension that you think about kidney. You make sure you do the right coding in the GP notes. Make sure the urine albumin creatinine ratio is tested. Blood pressure targets are one thing, personalization is the main thing. And when you're managing patient in front of you, always remember it's the patient, not just the disease that you're managing. And long-term conditions are incredibly common, as you can see on this on the graph. If you got kidney disease, you got more than 3 other long-term conditions. If you got hypertension, you got 2 other long-term conditions. So they all need to go really hand in hand. So thanks for listening, and any questions I'll answer on the chat if you got any thoughts there. Thank you.
Thanks, Sunil. Hand over to Marsha.
Thank you. Thanks, Sunil. Hi, my name is Marsha Sherman. I'm a senior clinical pharmacist at West Leeds PCN and the CVD Clinical Lead at West Leeds PCN. This is a case study and some slides developed with Michelle Young, who is our heart failure nurse specialist, who unfortunately isn't able to attend this afternoon. Next slide, please. So I just thought we'd talk a little bit about background of managing heart failure syndrome, and in that syndrome we look at HFrEF and also HFpEF. First of all, looking at our HFrEF patients, I think hypertension in HFrEF patients is rare because patients are usually being optimized on the 4 pillars of therapy for heart failure, and all of these have blood pressure lowering effects, especially when used together as well. Targets for blood pressure for patients with HFrEF are individual, but we usually like them below 130/80. And obviously we focus for these patients, the focus for these patients is to optimize their heart failure therapy. And we're using, as Sunil mentioned previously, first line would be ACEs and ARBs, or Entresto in some cases, and then moving on to MRAs, beta blockers, loop diuretics, and more recently SGLT2s, along with lifestyle changes as well. Where U&E is allowed, we can also use thiazide-like diuretics. In the absence of fluid overload, calcium channel blockers can be used safely, obviously avoiding diltiazem, verapamil, moxonidine, and alpha blockers as well in the absence of BPH. In actual fact, most patients with heart failure with HFrEF are more at risk of orthostatic hypotension rather than hypertension when they're fully optimized on their treatment. So we need to monitor lying and standing blood pressure and also looking at their symptoms as well. Next slide, please. For those patients with HFpEF, prevalence of hypertension in HFpEF is slightly higher, around 60 to 89%. And obviously, for patients with HFpEF, we want to have good control of blood pressure because we want to avoid decompensation in these patients, leading to HFrEF. And not all of these patients will be on all 4 pillars as are HFrEF patients. They may be on diuretics for their symptom control, but they wouldn't necessarily be on all the other treatments as well. The target for blood pressure for these groups of patients is not lower than 120/70. However, in some patients, we would go a bit more aggressive depending on their symptom control. And again, we can follow the same pathway of treatment for HFpEF patients if needed, using our ACE, ARBs first line, and then moving on to beta blockers and calcium channel blockers where necessary, and diuretics. Next slide, please. And managing hypertension in those patients with LVH, again, same ACE and ARBs first line with calcium channel blockers or diuretics, and again a target systolic blood pressure of 120 to 130. Next slide, please. So this is Dave, who is a patient I met recently. He's 67 years old. He's quite a complex patient with quite complex comorbidities. He's a HFrEF patient with an ejection fraction of 35%, but he also has a raised BMI of 40. He's a type 2 diabetic. He's also got AF. He's a smoker, and he's not engaged with the GP practice since 2019. I'm not going to go too much into its other comorbidities because we're focusing on his heart failure and blood pressure. But his medication, looking at his repeat medication templates, He was on a very high dose of bumetanide, equivalent to 240 milligrams of furosemide, spironolactone, bisoprolol, ramipril, lipid-lowering treatment. He was on a Pixban for his AF, and for his diabetes, he was on metformin and Victoza. Dapagliflozin was started later, and again, gliclazide. He had a New York heart classification of 2. He didn't have any peripheral edema or orthopnea or PND, but he did have thirst and polyuria, and his blood pressure was high at 160/95 and an HbA1c of 121. When I finally spoke to this patient, he was non-adherent to the majority of his medications and hadn't been taking, sort of picking and choosing as he went along through COVID and with no engagement with the GP practice. Obviously, the one medication he was taking was his diuretic, but generally speaking, he wasn't taking anything else. He had a decompensated admission in 2012, which led to his diagnosis of heart failure, and it was his high blood pressure that probably led to him having heart failure with such a reduced ejection fraction. So there's a lot of issues there with this patient. Obviously, his adherence, his engagement with the practice, his uncontrolled diabetes, his uncontrolled hypertension, his lifestyle issues, and his diuretic dose. So we almost needed to start from scratch. Next slide, please. So the first thing that we did was try and engage, gain the trust back with this patient and try and engage him again. And we had a long discussion about his beliefs, his adherence issues, his trust issues, and almost we wanted to start from scratch. So the priorities were his diuretic dose, his blood pressure control, and the fact that he was non-adherent to the majority of medications. So we wanted to reduce his blood pressure, but also reduce his diuretic dose. So in agreement with the patient, we did reduce the diuretic dose over a period of time until eventually it got to 1 tablet daily. And at the same time, we started to reintroduce all those medications that he'd stopped taking. So his ramipril, his bisoprolol, his spironolactone, and we sequentially reintroduced these up titrating as we went, and obviously checking his blood pressure and his UNEs every time there was a dose change. In terms of his diabetes, obviously that was an issue as well. We referred him to a dietitian for weight control, weight management. We referred him to the diabetic nurse specialist and the GP, and we reintroduced his diabetic medication. He had a problem with Victoza more recently where there was a supply issue, and we did start dapagliflozin for heart failure, and also with the added advantage of diabetes control. However, he did have side effects to the dapagliflozin, so that was unfortunately had to be stopped, and he was started on some gliclazide to try and reduce that HbA1c. We titrated his ACE inhibitor and his spironolactone to maximum tolerated doses, and we did achieve the target of blood pressure of 130/80. Obviously, he's continually being monitored because he has multiple issues going on. But yes, that was quite a good case study around hypertension actually leading to heart failure syndrome. Thank you.
Thank you, Marsha. So I just have a few slides just to pull that all together at the end, and then we have. So as we can see, lots of these patients have got multiple. So what do we do in those people? So the main thing you might come across as we've been talking is around personalisation. So we should be individualising both pressure targets and also treatment on the basis of frailty, life expectancy, risk of orthostatic hypotension, falls, drug tolerability, comorbidities. Everything about that patient needs to be taken into consideration when we're making those decisions. Where there are multiple different targets, we generally aim for the lowest target unless that target is known to increase mortality in other conditions. So most people with hypertension should be given lifestyle advice, which can be really effective at reducing blood pressure. We've covered quite a bit of that there. So this slide shows you the benefits of each of those lifestyle interventions. And if you did all of those, for example, that can have significant impact on blood pressure alone without even starting medications. However, don't forget that we do have, you know, as Heather's mentioned, our frail population sometimes aren't suitable for those lifestyle interventions, and sometimes it ends up doing more harm than good. And we will have patients that have got heart failure, CKD and frailty, for example. So the frailty, I think sometimes depending on what's going on, will need to trump the other conditions in those situations. Advice can be given by lots of healthcare professionals, including community pharmacists, social prescribers. So we should be working with those that are around us. It doesn't necessarily have to be us individual clinicians. But it's just about keeping all of that in mind and the benefits of all of that in people with hypertension, irrespective of whether they have any of these conditions. Other bits to remember, so making sure that if people haven't got a history of atherosclerotic cardiovascular disease, so that's stroke or MI or angina, that we should be considering primary prevention with statins as well. So for people that are under the age of 84 that have got Q risk over 10, type 1 diabetes if they've had it for a while and Q risk over 10, or if they're over 40, and if they've got CKD with eGFR less than 60, or ACRs over 30, again, we should be considering a atorvastatin 20 milligrams. And the big change, as you might have seen, there's lots of education training going on around lipids at the moment, but we're not firing forgetting anymore. We should be rechecking non-HDLs after 3 months and adjusting those statin doses as required, or adding in additional drugs as required to bring that cholesterol down. In secondary prevention, we're aiming for LDLs lower than 1.8 or non-HDLs less than 2.5, and that is now included in QOF targets. Don't forget, with your QOF targets, you need to have managed those people by December in order to get your full lipid profile back by the end of the QOF year. And there are additional benefits from glucose lowering drugs, the CVD benefits in type 2 diabetes, and there's a new guidance out from the European Society of Cardiology in managing cardiovascular risk in people with diabetes. So SGLT2 inhibitors and GLP-1s do have massive cardiovascular benefits for those patients, not just for diabetes, but also with CKD and heart failure as well. Okay, that brings us to the end of the session. We have got 3 minutes left for questions. You can either pop your hands up, or if you want to pop anything in the chat, and we've got lots of people here to answer. No questions? Have I bamboozled you or covered everything? Brilliant. Okay, there's a little bit of extra learning on there, so Lindsay will be sending the slides out afterwards, and this is specific to sort of general hypertension care, because as I mentioned, we haven't covered sort of general hypertension detection and management today. So if you want to do some additional learning outside of this session, those are all free packages that you can access. Have any of the speakers got anything they'd like to add as a final thought? No? Okay, I thought we were going to run over, but we're 2 minutes early. Brilliant. Good timekeeping, everybody. Okay, thank you very much, everybody. I hope you've got a lot out of the session today. Take care.
Thanks for chairing,
Thank
Emily.
you.
Yeah, well done.
Thank you.
Thank you.